Okay, hi everyone, and welcome to our mid-afternoon learning track session for data strategies. It's a treat to be able to provide our fourth Housing and Services Partnership learning track in person instead of Zoom for the accelerator states. We do want to welcome, however, our live stream participants who are in listen-only mode. We also welcome two other technical assistance or TA initiatives here at the convening, the Health and Housing Institute, which the National Academy for State Health Policy leads, and the U.S. Interagency Council on Homelessness All Inside Communities and States. Through the needs assessment and your work with your coaches, we know data sharing, matching, and integration are TA priorities. This tends to be a very complex endeavor with additional players to engage and many technical assistants, administrative and legal minutia to bring together data sectors to achieve a big picture goal, like streamlining housing services and supports for program participants. Since we can't yet turn this over to ChatGPT to figure out how and implement this for us, we're going to do our best to break it down in a bit and give you some inspiration, best practices, and a little bit of planning time. So here's what it's going to look like for the next 87 minutes. Because we're in person, we've organized this as a workshop. We'll start with the Technical Assistance Collaborative, or TAC, has learned from working with states and regions to operationalize their data goals. Then Arizona, California, and Massachusetts teams members will talk through their goals, strategies, and lessons learned in a discussion panel format that the Corporation for Supportive Housing will facilitate. And when the discussion panel ends, our live stream will end. But for everyone in the room, we're giving your state teams about 30 minutes to work at your tables to create a new goal or to revisit or perhaps update an existing data goal, then map out some steps using the TAC framework. If you want to later refer to these slides, please use them through the conference TA community site. And our first presenter is Alicia Woodsby, a senior associate with TAC, and please give your attention to Alicia.
Thanks, Ryan. Hi, everyone. I've been trying to figure out a way to make operationalizing a data goal sound fun. I haven't, it's still working on it. So I'm Alicia Woodsby. I've been a senior associate at TAC for nearly 4 years now. And prior to that, I worked at the state level for 15 years, partnering with, well, a big part of which was partnering with and working alongside an interagency group of partners that were looking to tackle many of the same issues that we are here to discuss today. I'm a social worker. I did not enter this field ever thinking that I would work as much as I do with data, nor did I ever want to. And I definitely did not understand that data use, sharing, and integration would be so essential for solving the complex social problems that we're all aiming to address. But I've actually grown to love data, despite myself, as I'm sure many of you have too, as you've seen what it can do and how much we need it to inform us and to guide us. And as is evidenced by the expanding body of data innovations and strategies that we're seeing across the nation through health and housing leaders and systems coming together to use data and data strategies and efforts to address homelessness and promote community integration for people with complex and chronic health conditions really across the lifespan. And if none of that convinced you about the importance of data, I'm sure Margot Krischel did this morning with her presentation. Next slide, please. So just looking across the states and district in the Housing and Services Partnership Accelerator program alone, there's some really remarkable data work going on. And this is just a sample of that. Engaging and leveraging, oh, I'm in charge of the slides. I'm sorry about that. Engaging and leveraging universities, academia, and other partners to look at data across systems to identify the highest acuity or high cost, high need populations, do predictive modeling, and track and evaluate outcomes. A Medicaid agency entering into an agreement to use Homeless Management Information System, or HMIS data, to implement a 24-month continuous eligibility policy for members experiencing homelessness. Partnering with managed care to identify people in the target population, and then work directly with service providers to engage them in services and housing. Implementing statewide data warehouses, some that integrate local HMIS databases and are working to include other health and social services databases. Working to create or enhance electronic health records and health information exchanges to coordinate care and improve care transitions across provider types. And several of you have matched, are matching, or are working to match statewide or district-wide data from Medicaid and HMIS to better understand population scope and needs, among other goals. So there's so much to be learned from states and communities engaging in data strategies to design Medicaid housing-related supports and services and to improve housing and health-related outcomes. And since many of you are already engaged in doing this innovative work and have achieved significant milestones in this space, we really want to use today as a forum for sharing what's possible and what it took to get there. So we hope the workshop at the end will provide a space for you to brainstorm with your team, with all of these possibilities fresh in your mind, to help identify some goals or just steps that can be taken to deepen your state's data strategies. Okay. So we'll focus mostly on the what it took to get there today, trying to distill some of what are the fundamentals of what it takes to operationalize a data goal and related strategies. We'll spend most of our time hearing from you and your colleagues who are doing this work. But first, I'm just going to briefly highlight some of the common components that we're seeing in states and communities that are using data-driven approaches. Obviously, knowing your goals, defining your data goals has been a really important first step and can encompass a whole variety of objectives, like understanding populations' needs, their needs for housing-related supports and services, determining eligibility for and identifying and prioritizing people for housing and services, screening for and flagging homeless and housing status in other systems data, assessing and addressing equity issues, making the case for investment in supportive housing and evaluating its impact, and improving coordination of care, for example, with hospitals, emergency departments, behavioral health systems, health plans, and others to improve outcomes for the people that you're serving. Partnerships with other data sectors, data owners and administrators have been used to identify individuals who are eligible for and most in need of housing and housing-related supports and services, and better understanding their needs, as well as resources to serve them. And we've seen that having someone in a key leadership position champion your data goals and strategies has been a pivotal factor in whether it happens or not, as is buy-in from other key leaders and partners, like from your state budget office, for example, which champions have been able to help to generate. Interagency councils on supportive housing, homelessness, or a similar focus have been used to drive and accelerate the pace of data sharing and innovations in several states. And there's definitely, actually, I think that's on the next slide. There's definitely a component around assessing the need for infrastructure investments and planning for ongoing operations and maintenance in advance of implementing a data-driven strategy. For example, if you're looking to create a technology platform that allows for data interoperability, creating a statewide HMIS system or integrated data warehouses, and just implementing a data quality strategy. As mentioned earlier, several states have looked to partner with academia or researchers to bring on that data expertise and analytic capacity, or they've created positions or contracted, whatever the particular path that it's taken, building that analytic capacity and that data capacity can really enable a state to fully pursue the benefits of the data integration strategies. And then all of our favorite component, as most of you all know, navigating privacy and confidentiality protections in legal frameworks are major components for those engaged in this work, including the development of data use or sharing agreements, the approval process for data sharing requests, working with your Medicaid agency counsel maybe to try to move them to a yes, the consent and release of information processes. Data sharing agreements, as many of you already know, are really important because they really lay out and establish the purpose, the process, the type of data to be exchanged, who can use and receive the data or information, and any legal responsibilities an agency might have. So also, similarly, developing and implementing the release of information is a whole process, or can be a whole process in and of itself, such as maybe integrating a release of information or ROI process into HMIS or multiple HMIS databases. So one of the things that we've seen is surveying data activities that may already be occurring in your state or locally that can be leveraged. Maybe data agreements that have already been established that can be built upon has been really helpful, as well as initiating that data use agreement process way earlier than you think you need to, because it often takes longer than is expected. And finally, eligibility and access. And this component really largely focuses on determining eligibility criteria and then a process of identification for services and assuring that this is aligned with the process for eligibility and access for housing. Some states and communities use HMIS and, for example, the COC's by name list to establish eligibility and to prioritize participants for available housing options, because it can be used to identify those currently experiencing homelessness in real time, and to identify and track high acuity and households experiencing chronic homelessness. Although we know there's challenges and issues with that as well, as we talked about a lot today in our roundtable discussion. But communities can match this data with Medicaid and behavioral health system data to better understand the population, who might be Medicaid enrolled and involved with other services and systems, and to assist communities in prioritizing for available housing and services. If all that didn't put you to sleep after lunch, in a nutshell, this is all to say there's some really cool work going on and some fundamental components that we're seeing and are emerging that can be looked at to help guide us all on this journey. So with that, I will, it's now my pleasure to turn it over to Kim Keaton, Director of Data and Analytics at CSH. Kim will facilitate our discussion panel and has been a partner, oh, you got it, in planning this session. So please join me in welcoming Kim in the panel.
Good afternoon, everybody. Is everybody nice and awake after lunch? So yeah, I'm Kim Keaton, Director of Data and Analytics at CSH, the Corporation for Supportive Housing. I lead a team of data analysts, and we together direct our internal and external data strategy. Unlike Alicia, I got into this field because I love data. And I love solving problems with data. I think in particular, my passion is around and has always been around cross-sector approaches that are really looking to solve, sort of how people utilize systems and reduce that system impact and turn it into a positive outcome with housing and services. So I am super lucky to have been able to get to know our panel and to be invited to moderate them today. I'm going to let them introduce themselves and then we'll kick it off. Go ahead, Glenn.
Hi, everyone. Sorry, just make sure this works. Glenn Sang, I'm the Policy Advisor for Homelessness and Housing at the California Department of Healthcare Services.
Hi, everybody. Yeah, okay. I'm Emily Cooper, and I'm a Special Advisor on Housing at Mass Health, the state Medicaid agency.
Hello, Liz DaCosta. I'm the Housing Program Administrator with Access, the state Medicaid agency in Arizona.
Great. So thanks for doing that. So as you'll learn throughout the panel here, each of these states are deploying a novel and innovative approaches to creating a data sharing environment that will allow for both population level and some individual level data. Not to say that each state, everything's going great in every state, because as we know, data sharing is full of challenges, mostly around privacy and releases of information and all that interesting stuff. We'll get to hear about both of those, what's working and what's not working, through the course of the panel. So I'm going to go ahead and start with you, Glenn. Just generally, what has been California's data goal that you started with, and why?
I've been thinking long and hard about this question. It's just, I think the best way I can approach this is just taking it back several years ago when California really embarked on a whole person care approach. So, the coordination of the health, behavioral health, and social services in a way that's very patient-centered. And, where we're at today is, we have our population health management services, which we've embedded into our managed care plan contracts as of Jan 1, 2023. So that is a requirement all of our plans have to take up as of Jan 1, 2023. So population health management, what is that? So it's, better interventions and ensuring access to a comprehensive set of services, based on the need of certain populations, based on risk, based on tiering. So when we look at our homelessness population, we understand, through different data sources, data strategies, what is it exactly to best meet their needs. Also addressing some of their upstream services, upstream drivers of health, such as housing. So when I talk about population health management, it's more than just our own healthcare data. It's more than just our behavioral health data. It's looking at data across the board. So there's a number of strategies we're embarking on to, pull in data from our homelessness data information system, which captures all of the HMIS data at the state level. So we're close to our first agreement on that, where we're integrating the data, pulling that together. And I think that that's really going to start help informing us more and more about the members, that we're serving. So, with that, the larger goal, is, like I said, leveraging the different health and social data that's out there, looking at claims, referrals, authorizations, looking at, going beyond that too, like looking at a member's SOGI, so their sexual orientation, gender identification, looking at their race, ethnicity, looking at the justice involved population as well, different housing reports, disability. So looking at all that in one patient-centered way, once we have all that data compiled and combined, how are we using that data to better inform our strategies? What better interventions can we make? How are we ensuring, there's health equity across the board? So, one of the examples I give is, previously a lot of, healthcare systems, like their algorithms account for high utilizers, highest cost patients. But when we pull the layers of the onion back on that a little bit, it tends to be white individuals who have the highest cost. So not necessarily Black individuals, but we know our Black population in California is overrepresented in our homeless community. So there's a disconnect there, and that takes further, data to inform, like, how are we creating better access? How are we better informing the outputs into our algorithms so we're meeting the needs and ensuring that there is health equity and we're reaching underserved populations? So I'll stop there and I'll pass it on.
Thank you. That was great. What about Massachusetts, Emily?
Thank you. So I'm up here actually having a strange feeling that we're being sort of profiled for our data work when they asked me, so what was our goal? I don't think we had a goal. I think we were just really frustrated and really just aggravated. And we just started trying to address what the issues were. It wasn't like the Medicaid agency, oh, we want access to the data. Most of what we've focused on is related to the Homeless Management Information System, or HMIS. I also think the question that we got, what was your state's goal and why, is interesting because the state has no role in HMIS. There is no official role whatsoever. HMIS is a relationship between a local continuum of care and HUD. And it's made it very interesting to try and walk in that data conversation when you don't have any role or ownership, or you know, we're sort of like over here saying, hey, hi, love to talk, love to chat, let's do something together, but it's not anything that we have any official role in. When we started this process, so I've been at this job for about 8 or 9 years, and I think the conversation was way before me. We had 18 continuums of care. Plus, we had a family shelter system that the state ran, which was another 19th data source. By the time I got around, we were down to 12, which is good. But we decided actually participating in a, what is it, IAP, Innovation Accelerator. Yeah, all the feds are nodding, right? That was a while ago. We actually happened to bring the right person to the team who had purse strings in our government. And we said, well, we'd love to put together a data warehouse, but the continuums can't pay for it. And they're not going to do anything that is more work for them. And she said, how much does it cost? Told her, she said, I have that in my couch. So that was great. So the goals were, I think, multiple layered depending on who you talk to, right? The goal from the state's perspective was we have no way if we're to tell if we're making an impact. All of these, I got to 0, I got to functional 0 at the continuum level. We couldn't do anything at the state level. We had no idea if we were addressing homelessness or not, because none of these data systems, they're all separate. All 12 different data systems did not talk to each other, and they weren't aggregated in any way. We also had a lot of folks saying, hey, well, everybody comes to this town for services. They're not actually from here. They come here because they like it here, and they're not actually from here, right? And so continuums were like, we want to see how people move around throughout the state. And the last thing is that we wanted to sort of have this data to inform planning. So at a state level, we definitely wanted access to the data. Keep in mind, Medicaid was not even in the discussion at this point. We're just bringing together 12 data sources. The continuums of care took about 2 or 3 years to convince to participate. They did not want any extra work, so we had to make it either we had to pay them, which we aren't, or we had to just make it a push of a button. So they get to push a button, and that's all it's supposed to be. And we also told them they could do all their HUD reporting through this system. So that was the carrot. We said, if you come do this, we'll make your HUD reporting better. And we paid for and stood up a data warehouse, which when we move on to next questions about challenges and other things, we can talk about. But I think the key part is that everybody at that table has a different need or incentive for being there. And it took a while to figure out how to please everybody. Whether it is we needed money, or we needed reporting, or we needed it easy, or we just wanted access to the data. It's taken a while, and it's based on, frankly, relationships and continuing to curate those relationships between the continuum of care and state agencies and other continuums and things like that. I'll stop there. You're up, Liz.
Great. Yes. So ours in Arizona, it's actually named now. It's Dwell AZ, our data warehouse enterprise linkage for Arizona. And it really actually came about from the community. So the state Medicaid agency is just a partner in this overall collaborative. But our goal was to understand that actually we're going to require the least amount of resources, and it appears to be able to have the highest level of impact when it comes to care coordination for our members. So we want to see, as a result, improved experience for our members and our direct service provider through our participation in this collaborative. I think it's really important too. I've been working on this now for 3 years, and I always have my individuals who help me really understand the importance of getting to yes. So when you're knocking on the door of the privacy officer, you have your reasons for advocacy. And so I want to share a story about an individual who, in the height of the pandemic, we opened up a community-based organization called St. Vincent de Paul, opened up their dining hall to allow for people experiencing homelessness to come in and sleep at night. And so every day they removed the tables, they set up cots, and there was people just lined up outside in the heat to be able to come in. And there was one elderly woman in a wheelchair who was extremely frail. And I'll never forget her wheeling herself to her cot and not even being able to lift her legs to be able to lay in there. It's a sight that I don't think any soul out there would experience in person and not just be, tasked with trying to do something about it. But we were a behavioral health organization that came in to try to support this community-based organization. So I had access to the Medicaid system to be able to look this individual up. And interesting, she was on a forensic assertive community treatment team. So one of our highest intensive community-based services. So what we envision with our Dwell AZ project is twofold: data analytics to be able to inform decision-making and track outcomes, but also a system where a case manager in a community-based organization at a shelter or a forensic assertive community treatment team can log into a data warehouse and be able to have an interface that comes up that tells them some of the most important information they must know about that member to be able to coordinate care.
Thank you. And I want to highlight and underline a theme that I heard from Massachusetts and Arizona, is that taking initiative to better structure our back-end data to how the patient or the client or whoever we call it uses our systems, right? I think that the patient experience in the story you shared will be improved by frontline workers having access to, sort of more information. So thank you for those answers. So now I'm going to ask each of you to maybe list one or two of the biggest innovations that got you here to where you are now. And we can start again with you, Glenn.
Sure. I think one of them is, I talked about the collection of data and our efforts to get our hands on more data to better analyze, the trends. And, really to me, what that means is, how do we follow a member through their whole journey, right? So, with our population health management, we do have a framework. So it goes, from gathering member information through like their data, their screenings, their assessments, and then also to, understanding their risk. So what's their risk? So performing a risk stratification segmentation, and then also risk tiering. So essentially, with risk tiering, placing them in high risk, low risk, medium risk, also with risk stratification and segmentation, just separating the member populations, into different risk groups based off of the information and data that we have. So with this, we could really start looking at, with this framework, we could start looking at the trends for each member. We could start looking at where are the gaps in services, what are the likely outcomes, and this really gets us into more predictive analytics. So we can start seeing like where the gaps in services are, where are they falling through the cracks potentially, or where are we needing to provide more service delivery or different outreach engagements? How are we addressing their social drivers of health and removing those issues for our members? Another thing, I don't know if this is quite an innovation, but it's we did put it in all of our plan contracts, so that all of our managed care plans do have to provide the population health management service, and they do have to meet National Commission for Quality Assurance accreditation, all by
I think
2026. So
that counts. No. That's enough. I didn't mean for you to stop. I said I think that counts as an innovation.
Sorry, but yeah. So putting those requirements in and just really setting the expectation that we're wanting to use, these standards, but then really leveraging the data best to our capabilities.
Okay, so fast forward, we now have a data warehouse, an HMIS data warehouse. We call it the Rehousing Data Collective. If you Google that in Massachusetts, you'll see we have a public dashboard. It combines data from 11 continuums of care, as well as our family shelter system, where it's aggregated and deduplicated, and we have different levels of security and user access. Just coincidentally, and I'm not getting any money from them, we are using the same vendor that Arizona is. which is Green River, and we were able to use open source code with them, and it was very, very cost effective that way. About a year ago or so, I started thinking about, well, wouldn't it be great if we could do some of this data matching between Medicaid and this data warehouse that exists? We have all this data now in there. What can we do with it? At our Medicaid agency, we only know if somebody's experiencing homelessness if somebody puts down a Z code, a provider uses a Z code, and that means they have to figure out the right Z code to use, which is tough, or the person actually needs to go to the doctor. We have, like 12 or 13% of people experiencing homelessness on Mass Health didn't have any claims in a year's time. So they just didn't have an interaction. Or the person tells us they're homeless and we make a notation in our system and they get a little flag. And I don't know that we ever take that flag off because we're worried, what if they lose their mail or something like that? So the data warehouse is run, or not in the day-to-day way, but it's oversight by a management committee made up of continuums of care. And they meet quarterly, and you have to go in front of them and plead your case for why you want the data, and they'll decide whether or not they want to give it to you, if they agree. So that is still a work in progress. But what became clear was I didn't really need the data in HMIS. I didn't need to know people's name or social security number or date of birth because we had that at Medicaid. All I needed to know was that they were experiencing homelessness. I had access. Somebody had already signed something saying, yep, it's okay for Medicaid to know your date of birth and things. So we kind of basically, duct taped or like came up with this around the bend system because legally nobody would share the data with us, and they still won't because the releases that the continuums have in place don't say I can share with Medicaid. Instead, what we are doing is paying the data warehouse entity. We gave them access to our eligibility lookup system called EVS, and on a weekly basis, they take all the data from HMIS that in that data warehouse that we've agreed on, and they run it through the Medicaid system. And anybody who comes back with a Mass Health ID, they just send us a list. So we get a weekly input of Mass Health IDs, nothing else. So the Medicaid IDs, we don't know anything else about the person, but then we are able to take that information and do things with it, right? We can do policy. So we're granting continuous enrollment or continuous eligibility for 24 months for people who are in that file who meet, certain criteria. So we basically, and that was how we convinced the continuums of care to let us do this. We said, if you let us do this, and I can see that somebody's homeless, they'd only have to do their paperwork every 2 years. We are using it for rate adjustment for managed care. We are looking at how we auto-assign people to different managed care plans. And because not every one of our managed care plans provides HRSN services. And wouldn't you want the person experiencing homelessness to be assigned to the plan that provides services related to people experiencing homelessness? So we're starting to look at how people are placed, and is there ways to look at the algorithm. And we also have integrated it as a data element into all our sort of queries. So we can query, let's look at this managed care's performance and all these things and who they serve and blah, 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 and how many people, according to this, are experiencing homelessness. What I will say is we're definitely using it as a population health level, not an individual Glenn is homeless today. And we can talk about that, and some of that's data quality. Some of it's just also transitional people's situation changes on a day-to-day. But so we kind of went around because we couldn't get legal sign off on releases, but now Medicaid is getting weekly data about who is experiencing homelessness according to our data warehouse.
So for us, it's always watching what Massachusetts is doing and then considering how we can incorporate it into ours. But I think really innovative too is our collaborative, which used to be called a governance charter. And it consists of representation from each of the continuum of cares. And it requires that someone with lived experience from each of the continuum of cares is also a part of the charter. Anyone who is a data contributor, so far it's Department of Economic Security and then also Access, makes up our collaborative. And so we are actually the ones who make decisions as to who's going to be able to access the data, what type of licensure level, how do we ensure that we don't just come out of it with data analytics information, but also with really good care coordination practices that are going to help the members and help the direct service providers see that improvement that we're looking for. The other thing is when we first started, we actually hired a company to go out and survey members and case managers to tell them about what we were trying to do and receive their feedback for what they would like to see within this system. And that actually energized everybody. And it gave us the focal point for what we must not forget, which is that we need to make sure that at the end of the day, the Department of Economic Security information is in there because they said they're tired of waiting in line at the Social Security office for an award letter to be able to provide it to their housing provider. It's taking hours and they're wondering why we can't just share that information without them needing to be present. And so those are the driving factors. The other was the Medicaid data. They really needed to know if a member had a serious mental illness designation, because if they do, they're eligible for clinical services with a clinical team within the state. There's a whole robust level of services they're eligible for that they can help connect them to. So they needed that information. So those were the really key, I think, innovative things that have led us to making sure that not only is the HMIS data in the warehouse, which we only have 3 COCs in Arizona, so hats off to Massachusetts there too, but the HMIS data is in the warehouse. And then also we are working on the processes for being able to share the Medicaid data, which is going to require a member consent. But we haven't ever lost focus of that because of that initial survey.
And then one more question for you, Liz, on Arizona. Are you guys sharing any behavioral health data as part of the agreement?
And so currently Medicaid is not contributing any data into the warehouse. There still are a few things we need to work out, but we have the infrastructure for how we're going to get there. A data share agreement with our administrative operator, a data share agreement with the data warehouse, Green River, a website that discusses the Dwell AZ process, and then also all of the providers that will be able to access that system, and then a member consent. So that's the key thing. But once that member consent is signed, we are going to be able to share Medicaid data, including behavioral health diagnosis, because the member has consented to releasing it. So it no longer is PHI. We are not going to be able to share the substance use data just yet because there's all those Part 2 protections when it comes to storing of it, but at least the behavioral health diagnoses will be able to go over as long as the member has consented.
Thank you. So now everything's going great. Nobody has any challenges, right? And I'd love to hear what are the biggest challenges you're seeing right now? Glenn, do you want to go ahead and start?
My answer might be a little more simple, but
It's okay.
I guess the attorneys, right? So,
Yeah, the lawyer. Right.
just joking. I love our attorneys. They keep us. My wife's an attorney, so I have to.
I didn't invite any of them to this convening.
But I think the challenges were the challenges were, of course, like we have like a big lofty goal to do like this robust data sharing across systems, departments, and agencies. And in California, we have like healthcare services, Department of Social Services, we have Department of Rehab, we have developmental and disability services, we have Department of State Hospitals. So there's quite a bit of data that we want to share along. But the way we try to go about it's like, well, let's just start off with what we can first. I'm just trying to tease this ahead of the next question, but it's but essentially it's the way we try to get around the challenges. Like, well, let's start off maybe a little smaller. What can we do right now? So I'll save the rest of that for later, but essentially it was working through different iterations of proposals, and it's still not finalized. So I don't want to say that we've made it quite yet. We're not there until I see everything signed on the dotted lines. But as far as challenges go, it's just making sure we get through the legalese and the agreements executed. That way we can get our first foot in the door. And I think once we do that, the possibilities just start opening up. Because for me, I'm like, well, can we have something as simple as a housing related flag for our members? That alone will go such a long way to start looking at the trends and start really looking at our members' journey through the health system in addition to all the other systems that they touch.
So I'm looking around and I don't see Richard Cho in the audience. And I was hoping this was our time when I could talk about the challenges and HUD would hear it, but maybe he's live streaming or somebody from HUD is, so I'll speak to it as if he's here. But one of the major issues is data quality.
Yeah.
And that's not something we can own. It is borne by the COCs and in their relationship with HUD. So at the state level, you know, the data we're getting in is based on the data we're getting in, but there are data quality issues. Ironically, some of the work that we're doing is surfacing those and addressing them. So one of the lists that we got with Mass Health IDs, our folks looked at it and said, well, 200 of those people are deceased. And so I went back to the data warehouse people and I said, according to our records, and so they went back and they were like, oh yeah, those were never updated. Got rid of those. So thankfully that's resolved. But we don't own the data quality. We also, again, aren't paying continuums to do this. It's an extra job, even if they only have to push a button. Of our 11 continuums, about half of them have arranged for nightly uploads into the RDC. The other half, however, have not. So the state said, okay, let's help you with that. And we put out grant funding so that they could change their systems to do nightly uploads. And a handful of them applied and a handful of them didn't. So we will still be in a situation where some of the data that's coming in is coming in quarterly, if that, whereas others are coming in on a nightly basis. So it is this relationship between the continuum of cares owning the data and being responsible for data quality and uploads that makes it a little bit difficult. We also have a fair amount of differences between our continuums as to what they feel they can share and can't legally, and whether or not they have a release in place. My understanding is that HUD does not require a release. They only require you to post something on the wall. However, many continuums have implemented and use releases, and as such, feel that they don't have the legal expertise to know whether or not they can share. So they say no. So we are not allowed at Medicaid to share our data beyond Medicaid. We can't give it to our managed care plans. We actually can't get any additional data beyond the person's Medicaid ID, like their name, or, well, we have their name, but I'd love to know what shelter they're in or what provider they're working with. And then I can give it to my managed care plan and tell them, we're paying you extra money through rate adjustments. Go out and work with this shelter provider and see what you can do, particularly now that you have HRSN services. I can't do that because it's data I don't own. It's owned by the continuums of care, and they need to agree to let us do that. So those are some of the challenges that we're definitely working through. Another challenge, I don't want to lose sight of this, is that when we put together the warehouse, one of the things that we actually thought would be really, really helpful was that if a person traveled across Massachusetts, we have a Boston continuum of care. Anybody ever been to Boston? Okay. Across the river is Cambridge. They have a continuum of care. It's one subway stop. You could walk it, take you about 10 minutes, right? And you might be in two different continuums of care, like in a different every day, because you like going to Cambridge, because you like that one on a Tuesday, what they serve for dinner, but on Wednesday, you're going to go to the Boston shelter instead. They don't talk to each other. So when Boston pulls up their information, they see that, Laura has been homeless for 25 days, and therefore she's not the longest homeless. She doesn't meet the chronic definition, all those things. Well, if they had the data from Cambridge and the other continuum they went to, maybe that person actually would qualify for housing for chronically homeless individuals because their length of time actually is longer. So we really wanted to be able to do some, lack of a term, care coordination, as they say in the healthcare world, but really looking at length of time homeless. And to do that, the way it's structured is you need to have the person sign a release and upload it to the continuum of care. There are about 16,000 people experiencing homelessness on Mass Health at any given week. We have 12 releases signed in the data warehouse. Maybe 20 the last time I checked. Sorry, Massachusetts, that I outed us. We're going to work on this afternoon. But that is the challenge. And we are not responsible for signing the releases. It is the continuum of care provider agencies. So we can give them things, and we're continuing to sort of tweak the system to see if we can make it work. But I think our challenge again is that the state doesn't exactly have a role between the relationship between HUD and the continuums of care around HMIS. Sorry.
So for our challenge, it really started off as a community initiative. And about 3 years ago, folks were concerned about the data warehouse living within a state agency. So the infrastructure really began with an award from a foundation for our Arizona Housing Coalition to be able to do a request for proposal to select a vendor. So that's how we were able to get into an agreement with Green River. But we found too, though, we want to make sure that the governance charter at the time, now called Collaborative, had the voice for how that system was used. And so we didn't have an infrastructure, though, for how the governance charter would be able to get into contract with new organizations and continue on the contract with Green River. And so at that time, we identified we needed to either become a 501c3 or RFP for an administrative operator who could really take on the role of that Arizona Housing Coalition. And so when I mentioned like the importance of finding your reasons to get to yes, we had to take back the question, both the Arizona Department of Housing, which is a state agency, and Access, to our Office of General Counsel. Hey, can we become a 501c3? And I mean, the answer is no, right? But those are a state employee cannot go off and start a 501c3, right? But those are the type of questions you have to ask, because sometimes the community wants to get that no. So then it can lead us to the other route we planned on taking, which was this request for proposal for an administrative operator. And so now we're in this interesting space of the administrative operator will serve as the backbone agency of the Dwell AZ warehouse, indemnifying all of the data contributors, and also being the contract that's tied back to the entity that we can all hold as true and correct, and we all can hold each other accountable to. But what we've done is we've built into that an exhibit that leads us back to the collaborative that says that when it comes to decision-making, recommendations will come from the collaborative. And so we had to change the name at that point. You also can't call yourself a governance charter, right? So how about you go ahead and change that term so you don't appear as if you have this like authoritarian position over everything. It really ties back to the data share agreement between the state and now this administrative operator.
So I thank you guys. I am getting like this from down here. And so I do think we have to skip our last question. But when you go back to your tables, you can answer the question of what the new goal you're working towards now. So I'm going to turn it back to Ryan, who's going to go over the exercise. Thank you to our panelists.
Yeah, so we actually have time for one more question. Sorry.
Oh, great. I thought we were behind, but it turns out we have a little bit of time for questions. I know this group has been really engaged with some of the other panels and presentations. So I'm curious if anyone has any questions for our panelists and you're brave enough to ask them. Thinking about it. Looks like maybe not right now. Maybe oh, 2 hands came up. Okay. Your microphone's coming for you from behind. There we go.
Hi, John Fuji from Hawaii. Hi, Emily. Question for you. I heard you say that you're wanting to match up the HMIS data with your data that you have on your Medicaid side so you can know who to auto assign to, right? And so the services can be delivered appropriately. So, but how do you pay capitation now if you're not sure who, or you just pay capitation for all the members? Or do you only grab the folks that are in HMS and you pay capitation that way? I'm not sure how you guys do that.
Just start with, I am not the Medicaid expert. I'm the housing and homeless expert. But what I will tell you is right now we have about 5 or 6 flavors of managed care at Mass Health, and our HRSN is only in one of them, and we do rate adjustment differently in different types of plans. The what we had been doing before. We did rate adjust for homelessness and housing insecurity using Z codes and using how many times somebody changed their address. We are now moving for people experiencing homelessness to using more of this data-driven approach in addition to Z codes, because we don't want to miss folks. But what happens is we have 3 types of plans that when somebody comes in and they haven't selected one, we will auto assign them to one. These are for folks who are not duals and who are younger than 65. And a lot of that's driven by where they apply geographically and sort of how many we gave to this plan last time versus that plan versus that plan. So we have sort of a formula on the back end. And the question is that formula working for people experiencing homelessness? So one of the things we're doing is looking at the data that comes in on a weekly basis to see how did we auto assign them? Because we don't want to get away from choice. If they could choose whatever plan they want to be in, but if we made the choice for them, was it a good choice? And so we're going to look at that sort of in a trending way to see how that is, and then figure out kind of then we would auto assign somewhere else, and then capitation and risk adjusting happens just based on how many members and what they experience. So we'd figure that out.
Yeah, there's one question right there. I think the microphone's right behind you. Yeah.
Hi, Elizabeth from DC. I'm curious if any of you have explored or have made connections leveraging your health information exchange, and particularly around how that supports like coordination of care between health and non-health entities.
So I'll say a couple things to that. One, I know at local levels, there's various efforts for like social health information exchanges where, the local entities between like HMIS, different health systems, behavioral health are all sharing data into one portal. So that's happening currently. At the state level, what we're doing, I mentioned this a little earlier. So our California Health and Human Services Agency, Centers for Data Innovation and Integrate. Josie, am I saying that right? Integration or innovation? Okay, there's 2 I's in it. Okay, but anyways, at our agency level, what they're doing for us is they're creating a data hub. So in that data hub, my department is sending our Medi-Cal data sets. In addition to our Department of Social Services are setting their data sets up into the hub. And that hub is also capturing our HDIS information. So our HDIS, like I said, it's kind of like the state hub for all of the local HMIS data that goes in there. So just a lot of triangulating, I guess you could say. And between those systems, we're close to executing our first agreement or first iteration of it at least. So from there, I can't speak too much because it's not fully executed. That'll really be our first foot in the door to start really having that more robust data intertwined together.
And I will
We're going to do one more question and then we'll have to move on. Yeah, go ahead.
Yes. Good afternoon, Ayako Tsumi from California. What tools or tactics do you have or do you wish you have to better identify and prioritize older adults at risk of or currently homeless, since they are arguably more vulnerable than the general homeless population? What tools do you have, or what tools do you wish you had to prioritize older adults?
So I'll jump in because if you look at my title, I'm actually work for the Medicaid agency and the Executive Office of Elder Affairs in my state. So this is something that comes up often. So the first thing is, I think, and I keep saying this and I apologize, that it's when we're talking older adults, we're not always talking the same people that in healthcare are older adults. So when you talk to healthcare about older adults, it's often people 65 and older. Going back to the panel this morning, there was a lot of people 50 and older. So I think from the healthcare side of things, we need to deploy different things depending on if somebody is younger or older, because at least in Massachusetts, we have different plans for people who are on Medicare and Medicaid than we do for people who are on just Medicaid and are younger. So it's a little bit complicated. And it's a nut that we obviously have to start talking about more because of this growing incidence. But many of the people between that 50 and 65 year age are the target focus for our HRSN services that we're about to deploy. So we are, very much, that's kind of the folks who are there that we're focusing on.
Okay, I think that we have to stop now. Just give the folks time, but maybe you guys can catch each other after. Ryan, why don't you go ahead and go over the exercise?
Great. Well, let's give another round of applause for the panel. That was really good discussion. And first things first is we're going to say goodbye to our virtual participants. Thanks for tuning in, and we hope you've enjoyed the past 2 days.